Hello and welcome to Orthodontics Part 1. This presentation is directed toward dental assisting students. We'll be looking at the definition of orthodontics, indication and contraindications, etiology, phases of orthodontic treatment, diagnostic aids, types of occlusion and bite relationships, principles of tooth movement, and charting. So the definition of the specialty of orthodontics has to do with the development, growth, and corrections of the dentofacial structures. We know from our dental knowledge that the bones of the face and certainly the position of the teeth influence the aesthetics of a person's face. And so what orthodontics does is to help correct those by tooth movement, mandible movement, and you can see here in this photo, even as the child is developing, you can see the profile here has changed immensely with orthodontic treatment. Indications and contraindications for orthodontic treatment. Indications include deviation in bite, aesthetics, malalignment of the dentition, malocclusion of the dental arches, spacing due to partial anodontia, impacted teeth or supernumerary teeth, diastema or diastemas, post-surgical and psychosurgical. The terminology that was just presented, my students, you should know that terminology somewhere in your brain, and if not, you want to go back and review. I will talk about post-surgical and psychosocial though. Post-surgical would be if a person had surgery or orthodontic surgery for jaw movement or some type of surgery on the jaws, and then orthodontic treatment, maybe traditional corrective orthodontic treatment would be indicated. And psychosocial has to do about how a person feels about themselves in a social setting, but it also could just be by themselves, not in a social setting. They may look at their appearance and not like the way their teeth look, and so they may have low self-esteem because of the way they look or the way their jaw is positioned. And so orthodontics can help with those facial structures, and only one type of treatment, of course, that could contribute to self-esteem. Contraindications would be poor oral hygiene. It's very important to have good oral hygiene with orthodontic treatment, more so that there are no consequences post-orthodontic treatment. And poor oral hygiene can be for various reasons. Lack of permanent dentition. So there are some preventive measures for primary dentition, but usually a child has permanent teeth in order to begin orthodontic treatment. They're unable to cooperate. Now, I put immaturity, but there could be a variety of reasons. First of all, immaturity. Maybe the parents are all gung-ho for the child to have orthodontic treatment, but the child doesn't want to cooperate, or the teenager doesn't want to cooperate. They don't want to do home care. If there are any appliances that need to be adjusted, they just don't want to do it. They don't want to wear the appliance. They may not want to show up for their appointments. So a variety of reasons, or maybe a parent isn't very good at keeping those appointments, unable to cooperate. Or if it's an adult patient, that could happen as well. Financially, they may not be able to afford it. They may have dental disease such as caries or periodontal disease, which would need to be treated before orthodontic treatment, or they simply don't have a need for orthodontic treatment. The etiology or the cause of dentofacial conditions could be genetics, developmental, environmental, or oral habits. So let's look at some photos that I have taken from the internet, so thank you very much. One could be genetics, where you have the size of the teeth versus the size of the arch. So if a parent has a small arch and the other parent has normal or large teeth, you would have crowding or malalignment of the teeth. If a parent has large jaw but very small teeth, then you could have spacing or diastema in the teeth, in the dentition. Supernumerary teeth or partial anodontia may also be part of the genetic etiology. Developmental, again, supernumerary teeth may be developmental and may not be genetic, or partial anodontia, or ectopic eruption. Ectopic eruption is when a primary tooth just isn't going to exfoliate. Okay, it's not loose, it's not moving. So the permanent tooth decides to find a different path, and it could be facially or lingually. Environmental is concerned with traumas at birth. Maybe there was some torquing of the head and the jaws during birth, or a trauma, some type of an injury. In this case, this is a soccer player with a sports injury that could cause dentofacial conditions. Oral habits such as thumb sucking can change the shape of the maxilla, the dentofacial structures. Use of a pacifier or bottles way past the primary dentition can cause, here you can see an open bite from the use of a pacifier. Mouth breathing, an oral habit. People who mouth breathe tend to develop a narrow palate, and you can see how it affects the alignment of the teeth. Tongue placement just could be a habit where people push their tongue forward, and that would change the alignment of the teeth. Tongue thrusting can cause open bite, or bruxing can change the occlusion of the dentitions. Tell me more. Here it comes. The phases of orthodontic treatment. There are three noted phases: preventive, interceptive, and corrective. So in preventive, we're dealing with the primary dentition. So the teeth should be caries-free, should be cared for. This is pretty sad, actually, but these teeth that may or may not be able to be restored are saving the space for the permanent dentition. So if they need to be extracted, then a space maintainer should be placed in order to keep the space for the permanent dentition. Appliances might be used to deter young children from thumb sucking or tongue thrusting. Interceptive orthodontics deals with orthodontic conditions that may be developing as the child grows or even as an adult. And so a palatal expander could be used to open the palate in hoping of preventing malalignment of the teeth or to minimize the malalignment. These I took from the internet. You can see this narrow palate before and then after. Another type of interceptive orthodontics is serial extraction. This is where the orthodontist or the general dentist practicing orthodontics looks at a panoramic image or a cephalometric image and determines that there is not enough space in the mandible or maxilla in the jaw to have aligned teeth. So the first extraction is extraction of primary teeth. The second phase would be to wait for the eruption of the permanent teeth. In this case, it's the permanent first premolars, and extract those teeth, leaving space for the other erupting teeth. Now, in this case, you can see they're kind of tipped, so orthodontic treatment would still be indicated. And then we have corrective orthodontics, which lay people typically know as braces. And we have, the metal, the wires, etc. Then, of course, we have our new corrective orthodontics with clear appliances that in a series of appliances can move teeth and realign them. These are just some examples. Again, I gleaned them off the internet, and thank you very much, of different types of corrective orthodontic appliances. We have clear appliances. We have, here's our typical appliance with colored elastic ligatures. We have lingual braces or lingual corrective appliance. And this I've really never seen, but I thought it was kind of clever, kind of cute. A bracket on a base of a star or a heart. Diagnostic aids that would be used to develop a treatment plan for a patient would be radiographic images, different types, cephalometric tracing, photographic survey, study models, a medical dental history, and a clinical examination. And if you're my student, I'd like you to look in your textbook and come up with examples of these types of diagnostic aids. If you're not my student, you can find this information in your dental assisting textbook or on the internet. Occlusion is a area of orthodontics that will normally be corrected by treatment. Generally, occlusion is the contact between the maxillary and mandibular arches, how the teeth occlude or bite together. Centric occlusion is when the person is biting in the most unstrained position, or what's called normal occlusion. So we use this occlusion in other areas of dentistry, such as obtaining a bite wing image. We want the person to bite down in centric occlusion. When a restoration is placed, we have the patient bite down and tell us, is it too high? Another type of occlusion is functional occlusion, where we look at or analyze the occlusion during mastication. So if a patient has TMD, a dentist may take articulating paper and have them masticate or chew around in contact with the teeth, and then look at where are the heavy biting or heavy points from the articulating paper and adjust those areas. Malocclusion is when you have abnormal occlusion. That would be considered cross-bite, extreme overbite, open bites, and we'll look at those in just a moment. Edward Angle is considered the father of modern orthodontics. Even though he lived a long time ago, many of his principles and research are still being used today. For example, we use Angle's classification of malocclusion. And I have occlusion in parentheses because we're starting to see that in some textbooks. So Angle studied occlusion of many different people and decided that he could determine different types of malocclusion and occlusion by looking at the relationship of the maxillary permanent first molar to the mandibular dentition. And we still use these today. So a class 1 occlusion is a neutral occlusion where the mesiobuccal cusp of the maxillary permanent first molar occludes with the buccal groove of the mandibular permanent first molar. And we call this neutral occlusion because the mandible is kind of in a neutral position in relationship to the maxilla. Class 2 is disto-occlusion. The mesiobuccal cusp of the maxillary first molar occludes with the interdental space of the mandibular permanent first molar and the second premolar. And I use a picture of The Simpsons because everyone in The Simpsons, even the pets, have a class 2 where their mandible is retruded or in disto-occlusion. We don't know about Maggie because she always has that pacifier in her mouth. Class 2 has 2 divisions, and they are related to the maxillary anterior teeth. Division 1 is where the anterior teeth are in labioversion, And division 2 is where the maxillary central incisors may be in lingual version or upright, and the lateral incisors are tipped labially or overlap the mandibular incisors. So this is class 2, has 2 divisions, division 1 and division 2. Class 3 is MESIOCCLUSION, where the mesiobuccal cusp of the maxillary first molar occludes with the interdental space of the mandibular second molar and the mandibular first molar. And I use examples of Bruce Springsteen sings in a class 3. Jay Leno may just have a protruded chin, but it'll remind you, if you remember who Jay Leno is, that a mesiocclusion where the mandible is protruded. Then we have some different bite relationships. We can have an overbite, which is kind of normal for many people, but sometimes it's extremed, where the maxillary anterior teeth bite over the mandibular anterior teeth. You can have an open bite where you see the person has occlusion in the posterior teeth, but there is no overbite whatsoever. It's just open in the anteriors. Or a cross bite where the maxillary teeth occlude toward the lingual side of the mandibular teeth, where normally our maxillary teeth, when they're in occlusion, the buccal cusps are slightly over the buccal cusps of the mandibular teeth, and this is the opposite here. Other occlusal form that's concerned with orthodontic treatment is curve of SPEE. So from anterior to posterior, most teeth have a subtle smile from anterior to posterior. So an orthodontist would be aware of that in the aesthetics and tooth movement. Curve of Wilson. Intraorally, we have a subtle smile going across from left to right. And so an orthodontist would need to be aware of this so that tooth movement, the teeth aren't tipped too far lingually or too far labially. So the principles of tooth movement involve 2 conditions. Force, which causes resorption of the alveolar process, and tension, which causes deposition. So the normal or usual corrective appliances of a bracket, an arch wire, and a ligature of some sort to hold the arch wire on the teeth, those 3 items are really crucial in tooth movement. It determines the direction that the tooth is going to be moved. The tensions on the wire, which is the magnitude, is important. How many teeth are involved, the distribution of those appliances, and how long is force going to be placed on the teeth in order to move them. Then tension is really important to hold those teeth in place so that there's deposition, so that the bone will, the osteoblasts will build bone in the area. Remember, osteoclast causes resorption. So again, we have the distribution, how many teeth are involved, the magnitude, how much tension, and how long. And this is, tooth movement is initiated by the application or use of dental appliances. Lastly, I want to cover the charting method. The orthodontic specialty is the only dental specialty to use the Palmer method. And if you remember the Palmer method, all of the teeth in a quadrant are numbered starting with the anterior teeth 1 through 8 to the posterior teeth, and then we use the brackets to determine which quadrant we are referring to for the teeth, and the same with the primary dentition. Well, thank you for listening, and I hope learning with Orthodontics Part 1, and look for Part 2 and 3 soon to be posted. Thank you.